All right, I think we'll get started. Good evening, everyone. Thank you so much for joining us this late in the evening. I love this turnout. This is this special interest group on critical care epilepsy. And I am Hiba Haider. I'm an adult epileptologist and associate professor at the University of Chicago. And along with my co-chairs, Dr. Nick Abend and Dr. Adriana Bermeo-Valle, I would like to welcome you today to our session. So before we begin, there's just a few housekeeping things that need to be covered. As the faculty may be presenting cutting-edge information and or unpublished data, we do not allow photos to be taken of the presentation content. About disclosures, it is the policy of the AES that all faculty participating in educational activities disclose to the program audience any real or apparent conflicts of interest related to the content of their talk. And disclosures can be found on the AES website. Claiming credit, the online evaluation and credit claim will be open until March 31st, 2023, and you must complete the evaluations and claim credit by that date. Pharmacy credits must be claimed by January 13th, 2023. And please see the AES website and meeting app for the list of accredited program content and further details on how to claim credit. Okay, so now that we have that covered, we have a really fantastic lineup of experts today who will give you an update on some of the therapies for status epilepticus that are options to consider beyond the use of first and second and third line agents, including anesthetic agents. Status is a neurological emergency, and estimated annual direct inpatient costs exceed $4 billion in the US. And much of this emanates from the fact that status becomes refractory or super refractory. And this results in the need for ICU care, mechanical ventilation, and treatment with high-dose anesthetic medications and associated morbidity. But for many reasons, much of which are beyond the scope of this SIG, the needle has not moved a lot in terms of our approach after we pass those first and second line options and anesthetic agents. And when it comes to real-world practice, many hospitals lack protocols for status epilepticus. And when they do have them, there's usually not a unified approach even regarding considering these options until very late in the course. So this is an area with many diagnostic and treatment gaps. So as we've done with this SIG for the last few years, we will start off with a data blitz. This is a 10 to 15 minute session that highlights some of the highest rated abstracts in this area submitted to this year's meeting. These are young investigators, junior faculty, graduate students, and they have put in a lot of work into these posters, and they will give us an update on their work. Unfortunately, one of them, Dr. Damien, cannot join us today due to some health reasons, so we will feature two abstracts. And with that, I will go on to introduce our first speaker. Our first speaker is Dr. Gabriela Tantillo. She is an assistant professor of neurology in the epilepsy division at Baylor College of Medicine in Houston, Texas. Dr. Tantillo was born in Puerto Rico and completed her bachelor's and a master's of public health at Harvard University. She completed med school at the University of Puerto Rico and her neurology, clinical neurophysiology, and epilepsy fellowships at Mount Sinai Hospital in New York. And as part of her research, she studies outcomes in status epilepticus, critical care EEG, healthcare disparities, and women's issues in epilepsy. And her poster, her talk is about disparities in morbidity and mortality in adults with status in the United States. So with that, we will go on to your talk.
All right, welcome everyone. Thank you for that introduction. My name is Gabriela Tantillo Sepulveda. I'm an assistant professor at Baylor, and thank you for coming to my presentation. focusing on disparities in morbidity and mortality in adults of status epilepticus, a national study. I have no disclosures relevant to the study. So our learning objectives are to review trends in status epilepticus, or SE, hospitalizations from 2010 to 2019, and to discuss factors associated with intubation, tracheostomy, gastrostomy, EG monitoring, and mortality, and to suggest areas of focus for further study and improvement. Status epilepticus is associated with high rates of morbidity and mortality. While disparities have been described in epilepsy care, their contribution to status and associated outcomes remains understudied. Our primary aim is to examine the relationship between social determinants of health and status outcomes and how these change over time. Secondarily, we wanted to study status epilepticus incident trends over a decade and assess factors associated with intubation, tracheostomy, gastrostomy, and EEG use, and to study incidence of mortality in adult patients with status. Our data source was the nationwide inpatient sample, years 2010 to 2019. Hospitalizations of status epilepticus were identified using ICD-9 and ICD-10 CM codes. Status prevalence was calculated and stratified by demographics. Joint point regression was used to analyze rates over time, and survey logistic regression was used to assess factors associated with intubation, tracheostomy, gastrostomy, EG, and mortality. So we identified nearly 500,000 hospitalizations during the 10-year study period, and baseline characteristics are shown in the following table. So here we have the SE sample in the third column. We see that there was slightly more males than females, and the prevalence was higher in males than females per 10,000 hospitalizations. Most patients were elderly, and the prevalence per 10,000 hospitalizations clustered in middle age to the early elderly range. Most patients, as we see, 54.9% were non-Hispanic white, followed by non-Hispanic black and Hispanic. However, the prevalence per 10,000 hospitalizations was highest in minority groups, particularly non-Hispanic black, followed by non-Hispanic others, which includes Asian, Pacific Islander, Native American, and Native Hawaiian, as well as Hispanic groups. The greatest group of patients were in the lowest income quartile, and the vast majority of patients were treated in urban teaching hospitals, 71.3%, with a higher prevalence per 10,000 hospitalizations as well. We wanted to look at the overall rate per 10,000 hospitalizations over time, and this is stratified by race ethnicity. So we can see that the rates increased over time for all groups. At the very bottom is non-Hispanic white in orange, followed by Hispanic in red dots, and then other in the garnet red, and then the overall trend is in blue, and then non-Hispanic black in green. So as we can see, there was an increase in all groups, but this graph is indicative of a great disparity in this disease diagnosis, especially for non-Hispanic blacks, followed by Hispanic and other groups. And I guess I'd also point out that not only have these disparities persisted, but they've actually increased over time. So here we have our survey logistic regression. Each column is a regression for that outcome, so intubation, trach, gastrostomy, EG, and death. So I want to focus on the impact of age, which is circled in orange in the first group, and we can see that rising age was associated in a dose-dependent manner with intubation, tracheostomy, gastrostomy, and death, with the highest risk in, obviously, the elderly group, 80 plus, with odds of death 6.5 times as high as the group 18 to 39, for example. Additionally, minority groups had higher odds of tracheostomy and gastrostomy, not necessarily intubation, with the disparity being highest for non-Hispanic blacks, followed by non-Hispanic others and Hispanics. EEG monitoring rose progressively of rising income, so that will be our first orange block here. And as we can see, the highest income quartile were 47% more likely to receive EEG monitoring compared to the lowest. Odds of EEG monitoring were also much higher in urban teaching hospitals, with the odds being nearly 13 times as high as someone treated at a rural hospital. All measures of complexity, so intubation, tracheostomy, and gastrostomy, as well as death, were also higher in urban teaching hospitals. In terms of mortality, minority groups, particularly non-Hispanic Blacks and Hispanics, showed a greater resilience to mortality with lower odds of death compared to non-Hispanic white groups. Rising income was also associated with a lower odds of mortality with an odds ratio of 0.9. And finally, mortality was higher in those with self-pay insurance with an odds ratio of 1.17. So putting it all together, this work shows that disparities exist in status epilepticus prevalence and rates over time, as well as tracheostomy and gastrostomy, with regards to older age, minority race, ethnicity, and income. Older adults and those of lower socioeconomic status have higher odds of death. Access to EEG monitoring is modulated by income and access to urban teaching hospitals. Older adults, racial and ethnic minorities, and populations of lower income or rural location represent vulnerable populations that require increased attention from health authorities in order to improve health outcomes and reduce health disparities. Urban teaching hospitals, as they see the bulk of these patients, may play an important role in this work. I want to thank my collaborators, especially the Baylor College of Medicine Center for Health Equity and my colleagues at Baylor, Mount Sinai University of Virginia. Thank you so much for listening to my talk, and I'll take any questions.
Yeah, Eugen Trinker, Salzburg, Austria. Thank you very much for this excellent work. I mean, these are colossal data, 400,000. So I have two questions. One is related to the measures you have. It's you are talking about prevalence, but status is a punctual event which lasts very short. So can you translate that into incidence, annual incidence for better comparability? That's my first question. And the second one is, we during that time period, over 10 years, there were two, I would say, major events. One was the EEG criteria for non-convulsive in 2013, and the other one was 2015, the classification. And we saw that the detection rate of status epilepticus went up for at least 10% in population-based samples when these two criteria were applied. So when you look at these curves, they look very, very similar and smooth upgoing. And you didn't see any changes which were related to these definitory criteria.
Yeah, so I think a lot of things have happened. So one of them was the change in status from 30 minutes to 5 minutes, which happened a little bit earlier, but it takes time for new definitions to be recognized. There's been, obviously increased use of EEG in ICUs and a greater understanding and recognition of non-convulsive status by neurologists and non-neurology providers. And the ICD codes changed in 2015, ICD-9 to ICD-10, and the number of codes for status substantially increased. So there's, it went from like 2 to 3 codes to like 15 to 20. And so, yeah, there's been definitely major changes in, clinical care, coding and reimbursement that might explain this increase for sure. However, I guess we would expect that to affect all groups equally. So I think that, that's the disturbing finding in this study. In terms of incidence rates, I don't have that data on me, but, we can roughly increase, surmise that they would be increased as well if the rates are increased. Mm-hmm.
Thank you. I have a question too. Do you know what was the percentage of patients that had epilepsy as a diagnosis?
Yeah, so, we did look at that as an additional regression analysis. I think the issue with this database is that we don't have a longitudinal component. There's no pre and post. There's no way for us to know whether somebody had epilepsy before the hospitalization. So we didn't think it was reliable to see, we really had no way of knowing whether they had it before. So, and we did actually run the analysis, and it didn't significantly change the outcomes. Thank you very much.
Okay, and our next speaker is Pilar Bosque Varela. She is a graduate student at Paracelsus Medical University in Salzburg, Austria, where she's also an epilepsy fellow at Christian Doppler Hospital in Salzburg. And she will talk to us about her work on duration of status that determines the development of periictal MRI abnormalities. Come on up.
So many thanks for the invitation to participate in this session. I'm very happy of being here. I have a little bit of jet lag, but I'm very happy otherwise. So I'm going to talk about duration of status epilepticus, how it determines the development of periictal MRI abnormalities. First of all, I would like to thank FWF for having funded our project in Austria. And I would like to show the main objective of this small presentation. So we want to identify periictal MRI abnormalities associated with status epilepticus in MRI. We want also to learn about MRI protocol, so which protocol is the perfect protocol for identifying these periictal MRI abnormalities in patients with status epilepticus. And we want to identify the factors which can predict the development of periictal MRI abnormalities. So right now we are performing in Austria this study. It's a prospective MRI study. It started in February 2019 until I would like to show some preliminary data till April of 2022. So what we are basically doing is we are recruiting patients with diagnosis of status epilepticus, so clear electroclinical diagnosis. So we are excluding those patients with unclear or ictal interictal continuum in EEG. And we perform MRI in the first 48 hours. So we do a specific status epilepticus protocol, which includes all the sequences you can see here in this slide. So diffusion-weighted imaging, arterial spin labeling, FLAIR, contrast perfusion as well, and T1 plus and without contrast. Also DTI sequences. So in this study we have different means, but right now I would like to focus on trying to answer which are the main factors which can contribute to produce these periictal MRI abnormalities, because it's still a very unknown question. So we don't know why some patients develop these alterations, why others not. So for that we are trying to see if the clinical duration could play a role in determining which patients are developing these periictal MRI abnormalities and which are not developing these alterations. So for that, we divided patients according to semiology, first of all. So we take a look if the patient is having a convulsive or a non-convulsive status epilepticus. And we all know this definition. So we have T1, so it's the moment in which we can make the diagnosis of a status epilepticus. And we know it's for tonic-clonic status, it would be in 5 minutes. For those non-convulsive with impair of consciousness would be 10 minutes. For absence, it's 10 to 15 minutes. Then there is another important time point, which is T2, and this point is when we expect that this patient may have long-term consequences. And this T2, as you can see here, it's different depending on the semiology of the status epilepticus. So it's in 30 minutes for patients with convulsive status epilepticus, being more than 1 hour for those patients with focal status epilepticus with impair of consciousness. And it remains unclear for those absent status epilepticus. So what we are doing in this small part of our project is basically we divide patients, these patients that we are prospectively recruiting into two groups, so patients with convulsive status epilepticus and patients with non-convulsive status epilepticus, and we divide each group according to this definition, so according to this T2. So we separate patients with longer duration than 30 minutes and shorter duration than 30 minutes in the group of convulsive status epilepticus. And we do the same in the non-convulsive patients, but with taking the limit of 1 hour. So our main hypothesis is that duration of status epilepticus could, and also semiology, could contribute to predict the occurrence of patients with alterations in MRI, of periictal MRI abnormalities. So far in this period, we recruited 256 patients prospectively. Out of these 256, 118 were included in this analysis because, as I mentioned already, we are only including patients with clear electroclinical diagnosis of status epilepticus. So here we're excluding all those patients with ictal, interictal continuum, or those unclear cases. And we are also including only patients in which MRI was performed with our status epilepticus protocol and was done in the first 48 hours after the clinical onset. So therefore, out of these 118 patients, we saw that 62, which would be 53% of the patients with status epilepticus, had periictal MRI abnormalities. So the main duration of this, the median of the clinical duration of status epilepticus of this group was 2.5 hours, and the median time between MRI and status epilepticus onset was 8.8. So we did a logistic regression with all these patients. So we took all these 118 patients with independence of the semiology type. And what we saw is that the longer duration of status epilepticus, the higher are the probabilities or the chances of having PMA, as you can see with a significant results. We also took a look, like I mentioned before, in patients with dividing per semiology type, so in patients with convulsive and patients with non-convulsive. And we can see here also in the logistic regression that we performed in convulsive status epilepticus, when we took the limit of 30 minutes, it was significant as well, as you can see here with a p-value of 0.03. And in patients with non-convulsive, we could see that patients with a longer duration than 1 hour had more chances of having PMA. So you can see 70% of patients with longer duration than 1 hour had periictal MRI abnormalities, while patients with shorter duration than 1 hour, only we documented this PMA in 33%. Here it was not significant, but it was nearly significant. And we think that maybe in the future we should divide more this group, because here we are including all the non-convulsive status epilepticus, absence status epilepticus, and maybe in the future we should divide it more. And finally, I would like to say that as we saw, the longer duration of status epilepticus, the higher are the chances of developing these periictal MRI abnormalities, with irrespective of status epilepticus semiology. The duration of status epilepticus may predict periictal MRI abnormalities occurrence, and why not, PMA could also help us to better define this time point T2, which is in certain cases like absence status epilepticus unknown. I would like to thank this wonderful team, neurology and neuroradiology of Christian Doppler Clinic. This is a joint project, and I'm happy to discuss with you. Many thanks.
Rob Stove, Boston Children's. A couple of questions, one for methodology. Were you including just single continuous seizures or to define status epilepticus, or multiple recurrent seizures? And were these time points defined by EEG to confirm that status epilepticus was ended? And I'm just curious about time of offset of seizure activity to point of MRI to, and how that might relate to some of your results.
So these patients were selected in the EEG lab, And for convulsive patients, we took the T1 definition. So after 5 minutes of convulsions, it was automatically convulsive status epilepticus. And for non-convulsive, of course, diagnosis was made on EEG, so with also the T1 point. And the other question was the time between diagnosis and MRI, right?
Well, one was if you were counting short recurrent seizures, or just a single long seizure.
We are making the diagnosis based on the definition of like electroclinical definition. So if it's a longer duration of 5 minutes, it's automatically convulsive. If we see a clear ictal pattern of more than 10 to 15 minutes, then it's automatically non-convulsive. It's like we do.
And then the other one was time point of offset. Like, just curious, like how much of this are we still seeing is like the time from your actual onset of, like you've got your time of onset from seizure activity, and that's your periictal MRI abnormalities, but how much of it is just like the post-acute changes in diffusion of that you might be seeing, and like how much time do you have from your MRI to offset of seizures?
So we normally take 48 hours. So we are actually in this analysis, it's only patients with the first 48 hours. So since the diagnosis is done, so since the patient is having a twitching for more than 5 minutes, then it's convulsive. So since the diagnosis is done, or since the ictal EEG pattern is seen for non-convulsive and is done, to the MRI. And we are only taking patients in the first 48 hours. So all of them underwent MRI in the first 48 hours.
So thank you. I'm Crystal Vonk from Ghent University Hospital in Belgium, and I'm just wondering, could you briefly allude to what did you see on the MRI? Of course, you showed a lot of sequences, but is there anything most typical,
We could really talk a lot of hours about this, but so we either see diffusion-restricted lesions, hyperperfusion. The most frequently alteration that we have seen is hyperperfusion, so ictal hyperperfusion, either in arterial spin labeling or perfusion with contrast. The second one is diffusion-restricted lesions, normally with a clear increased signal in DBA, but normally or not really decrease in ADC. And the third most frequently was flare alterations, but the most frequently one was hyperperfusion, ictal hyperperfusion.
Thank you very much to our Data Blitz participants. We will move on to the expert presentations, and I'll give you the outline here. As we all know, it is our, the reason why probably this room is full to the brink and we have so many people standing in the back is because, unfortunately, refractory status epilepticus is something that we are seeing all the time in our hospitals and ICU units, and many times we run out of options, or we feel we run out of options, or really medications and then anesthetics don't get us there or take too long to get us there. And we thought about this topic for this the SIG this year to bring together the other options that we have beyond medications and beyond anesthetics. And we are extremely excited and very grateful to our wonderful speakers to present three other treatments for the management of refractory status epilepticus. We will start with the use of dietary therapies in the management of refractory status epilepticus, followed by the use of neuromodulation, and finally immunotherapy in the management of refractory status epilepticus. We will leave all the questions to our expert speakers to the end, and we look forward to have a very engaged conversation about all of these wonderful options. To start with the use of dietary therapies in the management of refractory status epilepticus, it is my honor and my pleasure to introduce Dr. Mackenzie Cervenka, who's a professor of neurology at Johns Hopkins School of Medicine. with subspecialty training in epilepsy. Dr. Cervenka is the medical director of the Johns Hopkins Adult Epilepsy Diet Center and the Adult Epilepsy Monitoring Unit. She developed the Hopkins Adult Epilepsy Diet Center in 2010, which has treated more than 450 adults with epilepsy using ketogenic diet therapies. She conducts clinical trials examining the feasibility, safety, and efficacy of these diets, and also collaborates with many investigators to evaluate these treatments for patients, and for patients also with alcohol withdrawal, gliomas, Parkinson's disease, migraine, and dementia. On a personal note, Dr. Cervenka was instrumental to set up the ketogenic diet at Rush Epilepsy Center, where I work together with Dr. Balabanov. So personally, and from all of us, Dr. Cervenka, thank you for all you do, and thank you for joining us in your wonderful talk.
I must be blushing right now. If I'm not, I don't even know what to say. My goodness, thank you so much. I'm going to go ahead and pull up my slides, and maybe. Or maybe not. Goodness.
Just tap the pad and not click it. It's very finicky.
Okay. I won't touch it too much. Okay. So I'm going to talk about my favorite topic in the entire world, which is use of dietary therapies in the management of refractory status epilepticus. Thank you so much for the opportunity to come today. And wow, oh my goodness, there are so many people in this room, and thank you all very much for being here as well to listen to these wonderful presenters. So here are my disclosures. The disclosures I have that are relevant to the talk that I'm going to be giving today. I do have disclosures with Nutricia and with VitaFlow, which are both companies that produce ketogenic formulas, and I will be talking about dietary therapies and ketogenic formulas. However, I won't mention particular ones by name. All of my other disclosures are not relevant to this talk. The learning objectives for today are to define the potential role of dietary therapies, and in particular ketogenic diet, in the management of refractory and super-refractory status epilepticus, and to incorporate current recommendations and identify pearls and pitfalls in utilizing these therapies in a critical care setting. Now, you heard in the poster session this concept of time is brain, because we just learned that the longer status epilepticus goes on, you have these changes that happen in the brain, and we've known this for a very long time. We have learned as neurologists that you're supposed to treat stroke urgently. Time is brain. And I'm not sure why that hasn't caught on as quickly when we're thinking about status epilepticus, but we are still trying to move forward with that. And as you heard, going from 30 minutes to 5 minutes with the definition of status epilepticus is a good first step. And what has evolved over time are a variety of treatment algorithms that we all are familiar with for first-line, second-line therapies for status epilepticus. And really the ESET trial was very instrumental in helping us figure out what some of these therapies might be, what doses to use. And so now you can see just an example of some of these algorithms that are currently being used. Now, once those first and second-line therapies fail, as you all know, then we kind of call it the wild, wild west, right? So we intubate patients, we sedate them with general anesthetics. This is just an example from 2011 of some of the drugs. This was over 10 years ago. We're still using these same drugs, same doses, trying to sedate patients and hope that when we take away those anesthetic drugs, that in fact the seizures have gone away. And so that is kind of the current state of affairs with regards to refractory status epilepticus. And these numbers haven't changed too much since 2011. So what we know is that with refractory status epilepticus, I think of it as a third, a third, a third. About a third of patients will die. About a third of patients will survive but will have significant disabilities, and about a third of patients will actually leave the hospital and be able to return to baseline. And when we say baseline, a lot of those patients still have chronic epilepsy following discharge from the hospital. So really, sometimes not even to that point where how they came in initially. And then with super refractory status epilepticus, so we wait 24 hours, we either try really hard to sedate the patient and to suppress the seizures, and we're not able to do so in those 24 hours, or after the 24 hours, we take away the medicine and find out that the seizures just come right back. Actually, about 50% of those patients will die of super refractory status epilepticus. The problem is this is not a sustainable disease. You have to keep treating it, and there's no way to really be able to sustain life unless you're able to control it. And so there has been, and I'll come back to this later, a clinical trial that attempted to treat super refractory status epilepticus, and around 40% of the placebo group responded and around 40% of the treatment group responded, and that was with allopregnanolone. And so that at least gives us a picture of what our expectation is with regards to the current therapies or the current management that we have when we're talking about super refractory status epilepticus. So I just want to point out, take a moment to think about a patient who is sedated, who's intubated. Usually that patient also gets a feeding tube. That usually happens around the time of intubation. Some interesting things happen in the critical care setting, so we don't always feed patients right away, but actually just feeding patients. There's a lot of really good evidence that feeding patients can actually improve outcomes. But often we put the tube in and we just they hang out for a little while. So what you see here is kind of what a standard enteral formula is. It's sort of like the standard American diet. The majority of that formula is carbohydrate and a smaller percentage fat and protein. Now, my suggestion, something for us to think about as a group, well, could we order a different formula maybe? We know that ketogenic diet works for kids and adults with epilepsy. Why would we be giving them this high carbohydrate formula when we just have to go and place that order? So just something to think about. Now, I want to talk about ketogenic diet. It used to be I would talk about ketogenic diet and no one had ever heard of it. Now I talk about ketogenic diet and people will say, oh, I'm on that, or my grandmother's on that, or somebody is on that. So I just want to now tell you guys what the ketogenic diet actually is, because it is different, and we actually use the term ketogenic diet therapy among our group, or therapies, because these are really treatments, they're not fad diets. And so with the classic ketogenic diet, we talk about it in ratios. Ratios are the ratio of fat to carbohydrate and protein combined in grams. And so when we think of it that way, they're almost like doses. So a 3-to-1 ratio is a lower dose ketogenic diet than a 4-to-1 ratio. If we're talking about a patient who is able to communicate with us, who is able to swallow and eat by mouth, we would actually be weighing those foods with a gram scale in order to create the ratio that's appropriate for that patient. In the setting of status epilepticus, we pick out a formula, we order it, and the formula is ready to be used. Some centers and some protocols will use a fast at the onset of using the ketogenic diet. It takes about 24 hours for people to be able to use up their glycogen stores to start to get into ketosis, and so sometimes a fast can actually kickstart that. If you look at patients who are intubated and sedated in an ICU setting, often they have been fasting for a period of time, so that sort of kicks off the ketosis. And in fact, in our center, when we were first starting to look at this, I just looked at patients in their first 24 hours in the ICU, and they were in ketosis, about 14% of them, when we hadn't even started using the diet yet. And so just something to keep in mind. And so there are commercial tube feeds, and one of the advantages, several advantages, they contain multivitamins, calcium, vitamin D, so they're nutritionally complete. Potassium citrate is something that you want in your ketogenic formula because it can prevent kidney stones, and then carnitine supplements as if you're going to be using the diet long term. Fiber can help with reducing issues like gastroparesis and constipation. And then medium chain triglyceride oil is something that is in some ketogenic formulas, or you can add to ketogenic formulas. Medium chain triglycerides actually can be metabolized through the liver into beta hydroxybutyrate, acetoacetate, acetone, so the basic ketone bodies much more quickly than other forms of fatty acids. And so this is one way in order to be able to really boost ketosis. And when we talk about ketosis, what we're talking about is producing ketone bodies and achieving the state. Now, this is another question I'm going to get to, is what should our definition of ketosis be? We were talking about this earlier today. We really don't know. You know, we talk about the diet like a dose of medication, but we actually don't know just yet what the therapeutic level is with using a ketogenic diet. Now, if patients have intolerances, allergies, you can also use the diet with blenderized foods. And so with regards to anti-seizure mechanisms of action, I am not going to actually delve into this. I'm going to refer you to this wonderful review article by Rowe and colleagues, because as you can see, these are just topics of different ways in which the diet works, and underneath each of these topics are about 4 or 5 subtopics, because the diet is not like anything else. That's why you keep hearing about it being used for everything, is because it does so many different things. And what it does for epilepsy and status epilepticus is different than what it does for Alzheimer's disease or what it does for brain tumors. And so please take a look at that article, which is just fantastic. Now, one of the mechanisms of action that I was most skeptical about in the context of status epilepticus is this concept that actually it alters the gut microbiome and actually increases the proportions of Akkermansia and Parabacteroides in the gut, and that elevates the GABA to glutamate levels, and that can suppress seizures. And when I heard this, I'm like, that is fantastic. That makes perfect sense. Of course, this is why it works. But then I'm like, is it going to do it that quickly? And so I've been pestering the researchers that have done this work, and they tell me that this happens in a matter of hours. Now, this is in animal models, but it can happen in a matter of hours. And so possibly it still could be a potential mechanism in status epilepticus. Now, the other mechanism that I just want to draw your attention to is anti-inflammatory properties. So when we think about our patients with encephalitis, when we think about patients with NORSE in particular, we're looking at a lot of different therapies that you're going to hear about in just a moment. But one of the things that the diet has been shown to do in a variety of different conditions and models is to reduce pro-inflammatory cytokines and chemokines. It actually reduces local inflammation. And one of the reasons that we see that it does this is this elegant study that was done looking at actual beta-hydroxybutyrate itself, one of the ketone bodies that blocks the NLRP3 inflammasome, which decreases the production of these pro-inflammatory cytokines. And so you'll hear again about some of these different strategies for reducing inflammation, but guess what? The diet does it too. So like I said, the diet does everything, right? So how do we use the diet? Obviously, not everyone here works with a dietitian. Not everyone here has a center where they can just start the diet and push the button and order the ketogenic diet and everything works perfectly. So what is the protocol for incorporating it in the setting of refractory and super-refractory status epilepticus? It is an adjunct to anti-seizure medications. I just point that out because sometimes people get confused. They think, oh, we'll just start the diet and we'll take away all these other things. That's not how the diet works. As I mentioned, it takes at least 24 hours to be able to start getting into a state of ketosis. We don't know exactly how much ketosis is needed to suppress seizures, so you always want to still have the anti-seizure medicines. You always want to have the anesthetic on board and then start to take it away once you see that the patient has reached a state of ketosis. There are a whole list of labs up here, and that is because there are contraindications to the diet. So I said, oh, let's put everyone on the diet. That's not true, because there are, for instance, metabolic conditions that are very serious in children, and if you put them on the ketogenic diet, they will die. So that's where we see things like plasma acetylcarnitine levels, urine and plasma amino acids. Those are measured in children before they are started on a ketogenic diet. If it's a young child and there's any concern about one of these metabolic abnormalities, because you really cannot start those patients on the diet. Some of these other things are just to make sure there's no underlying deficiency that needs to be addressed. And then urine HCG is because we do not know if the diet has any teratogenic effects. If we're using it in refractory status epilepticus, we're probably using it for a short period of time, and there may be other concerns that we have on our minds as well, but we still just don't have an answer to that question yet. We always want a nutrition consult. We want to remove dextrose from IV fluids, change all medications to low carbohydrate preparation, and start a nutritionally complete enteral ketogenic formula, meeting estimated caloric needs. Now, I'll show you a couple of recommendation papers, one of which says use a 3-to-1 ratio diet in children under 18 months and a 4-to-1 ratio diet in children over 18 months, or in some cases 2 years and over. I'm just quickly going to go through these slides because each year I add a few more studies to it, and these are the studies that have come about in 2020 onward. And if anyone has done any studies that I've missed, I apologize and come talk to me afterwards. But these are the ones that I found. And what you'll notice in the very, very, very small print that you probably can't see is that these studies are looking at the feasibility and safety of using a ketogenic diet in the setting of refractory or super-refractory status epilepticus. The largest study is in 16 individuals. There are some in children, there are some in adults, there are some in both. Most are retrospective, and they are not comparison trials, they're safety and feasibility trials. So I will just briefly touch on a few of them. This was a study that we conducted with collaborators from Rochester, from the Queen's Medical Center in Oahu, and also Thomas Jefferson. And what we found is that in 15 adults, this was a prospective study, all were able to achieve a state of metabolic ketosis on a 4-to-1 ratio ketogenic diet with a median of 10 days after the onset of super-refractory status epilepticus, and 73% of enrolled participants had resolution of super-refractory status epilepticus. Remember, that's compared to 40% with these clinical trials that have taken place. This is another study that was done more recently looking at refractory status epilepticus. So these are patients that actually started the diet much earlier. So they started it after the anesthesia was begun. And you can see the majority were able to achieve ketosis in 1 day, almost all of them, a 10 out of 11, and 73% of enrolled participants had resolution. Well, gosh, that number sounds very, very similar. And here's another one. So this is a study done in 14 children. 93% achieved ketosis, and their ratios were anywhere from 3-to-1 to 5-to-1, and 71% of enrolled patients had resolution of refractory status epilepticus. So one of the authors is here in the audience, Neha Kaul, and so these are some practical considerations and practical recommendations about how to manage refractory and super-refractory status epilepticus in the pediatric and in the adult population. So a few important points as we're wrapping up. First of all, time is brain. I think I've said that enough times, so I can move on. The second thing is if you are trying to induce ketosis and you're having difficulty, consider medium-chain triglyceride oil, palm kernel oil, coconut oil, and then get pharmacy involved. This is a multidisciplinary approach to the management of super-refractory status epilepticus. So either avoid or account for lipid content in IB propofol. There is one study that actually showed a propofol infusion syndrome that resulted in the death of a child when it was combined with ketogenic diet. So just make sure that if you're considering using propofol that you're really taking into consideration that lipid content. IV drugs can have propylene glycol, which can suppress ketosis. We don't know if that affects the seizures or not. We have no idea, but those can be IV phenytoin, pentobarbital in some cases, and we do know that that can suppress ketosis. Tablets and IV medications have lower carbohydrate content in general than liquids and syrups, and just make sure if you have those perfect when you leave for the day that they stay perfect overnight, because there can be well-meaning people that might change things around in the middle of the night not realizing why you did that. So having order sets available, actually putting in that the patient is allergic to dextrose, those can be ways that can trigger your electronic medical record to not let that happen. And then you have to treat if the CO2 levels go down, because otherwise the patients can experience acidosis. And then finally, hypoglycemia. We actually don't know how much hypoglycemia we're willing to tolerate and when, so we don't know the exact cutoffs for when to treat. But if you overtreat, it takes another day to get back into ketosis. It's totally unfair. It's really hard to get into ketosis, and it's really easy to get out of it. So, time is brain. A ketogenic diet can be safe to start in patients of all ages with refractory and superrefractory status epilepticus. However, randomized clinical trials examining the efficacy of a ketogenic formula in the management of RSE and SRSE are needed. Thank you very much.
Thank you very much, Dr. Cervenka. We are moving towards neuromodulation. It is my pleasure to introduce Dr. Crystal Vonk, who's a professor of neurology in Ghent University Hospital in Belgium. Her medical training was in Ghent University, and her PhD thesis was Neurostimulation for Refractory Epilepsy, Clinical Efficacy and Mechanism of Action. He has held international training positions at Guy's Hospital in London, UK, Yale University School of Medicine, New Haven, Connecticut, and in the University of Stellenbosch. Her research interests include neurostimulation, bioelectronic medicine, and neurophysiology, and home monitoring in neurophysiological disorders. Dr. Vonk, it's a pleasure to have you. Thank you very much.
Okay, here we go. Thank you very much for this very kind invitation. And it's my pleasure, too, to speak about my favorite topic in my life, neuromodulation. Although it may not be in refractory status epilepticus, because there are certainly still a lot of challenges for neuromodulation in status epilepticus. These are my disclosures for today. My learning objective, I'm going to try and provide you with some preclinical background, some rationale for thinking of neuromodulation in status epilepticus, and maybe provide you a little bit of guidance on how to proceed in this topic. Now, neuromodulation in the field of epilepsy, I can speak, I think, about neurostimulation, concerns the administration of electrical or magnetic current in the vicinity of neuronal tissue in order to try and modulate neuronal activity. This in adjunct to what we have been trying to do and changing the brain with chemicals. We all know that physiologically our brain also works with electricity action potentials. So neurostimulation is actually targeting that part of our normal brain functioning. In epilepsy, because it certainly didn't start out in epilepsy neurostimulation, primarily in spasticity and movement disorders, but in epilepsy, when we started thinking about neurostimulation, we have realized in the meantime that there are various strategies that you can try and have and think about when you think about neurostimulation and epilepsy. There's bottom-up and top-down strategies, meaning that you can perform transcranial magnetic stimulation and trying to interfere with cortical-subcortical networks. Bottom-up is what we preferentially do with, for instance, cranial nerve stimulation, where you target the brain stem and then inputs towards the rest of the brain. You can try and work for a neuromodulatory approach, which typically takes a while to install itself, or in epilepsy you can try and actually immediately, acutely intervene with seizure activity. Maybe that's most relevant to what we are talking about today with status epilepticus. You can try and target the seizure focus and try and place an electrode somewhere in the brain when you know where the seizure focus is, or maybe also more relevant here, in the case of status epilepticus, try and interfere with what we call epileptic networks, or at least regions in the brain that we know are involved in epileptic networks, such as the hippocampus, the thalamus. We have randomized controlled trials and long-term follow-up available for efficacy and safety for 3 modalities of neuromodulation in epilepsy. That's vagus nerve stimulation, deep brain stimulation, and responsive neurostimulation. My talk will focus today on vagus nerve stimulation because basically only for vagus nerve stimulation we have case reports and even case series available in status epilepticus. Vagus nerve stimulation has become an old therapy already. It's certainly not new anymore. It has been approved as an adjunctive treatment for drug-resistant epilepsy many years ago, and it is indicated in unsuitable surgery candidates or patients who underwent unsuccessful epilepsy surgery. The long-term open data demonstrate that up to 60% of patients can become responders if we use vagus nerve stimulation as part of their total treatment regimen. Now we have seen all the devastating results of treating or just the occurrence of status epilepticus, and as there is a very high case fatality, often off-label products are tried in this condition. And of the neuromodulation therapies that we have available, we can certainly state that VNS is least invasive and that we have long-term experience with this therapy in many epilepsy centers. Also, there are some reports on the fact that patients that are being treated with vagus nerve stimulation for their drug-resistant epilepsy tend to have a lower incidence of breakthrough status epilepticus. So in that sense, we started thinking about VNS in status epilepticus, but of course there's two big groups, and we are talking here about treating patients with an expensive implantable device. So if you have a patient with drug-resistant epilepsy, that may be not such a big challenge, as maybe later on you can continue the treatment with vagus nerve stimulation. But of course, there's also patients with NORS, and there you are starting out with a relatively invasive therapy. In a patient who never had epilepsy before, assume that you can stop the status. The question still is, are we going to continue this therapy with this implantable device? Potentially also these have different effects based on different mechanisms of action, or different mechanisms may be required in both conditions. Certainly we don't know exactly the mechanism of action of vagus nerve stimulation, certainly not in status epilepticus. Hopefully there is a way to induce desynchronization in a hypersynchronized synchronized state. Now many years ago, previous to bringing the therapy to the market, there were many preclinical studies in animal models, and I give you a brief overview here, where basically most of the studies were performed indeed in relatively acute seizure situations. Most of these animals were under anesthesia, so it's quite difficult to extrapolate this to humans in the first place, and also to awake humans, or for instance humans in status epilepticus. And here, for instance, you see a very nice example of one of these preclinical data demonstrating that VNS, if you deliver it at the onset of seizures, was able to reduce the seizure duration significantly, in this case from 30 seconds to 5 seconds. So demonstrating that most likely, if we believe this data, that indeed VNS is able to have a relatively acute effect on seizure activity. Now, in the past years, we have performed a lot of translational research in this context in Ghent University Hospital, and we certainly designed optimal or more optimal vagus nerve electrodes to be used in our rodent models compared to the initial preclinical trials that were often done in an acute setting with an open surgery situation, and for instance also with preliminary designed hook electrodes where electricity can go anywhere in the vicinity of the electrodes. So since the design of these more miniaturized and more improved electrodes, certainly research has also improved. But if I checked all the research that we did in relatively acute seizure models in our lab, we found very conflicting results. For instance, one of the first preclinical studies that we did was deliver vagus nerve stimulation in the absence model in rodents. And basically what we saw, if we really acutely deliver it immediately after the onset of the seizures in these absence seizures, that basically we even were able to increase the duration of spike and wave discharges. If you have a continuous and, for instance, weekly treatment of these animals, they do tend to have a decrease in their seizure activity. We also looked at the motor cortex stimulation model, where basically we could demonstrate a relatively acute effect on cortical excitability, where we had to deliver more electrical activity to the cortex when the rats were treated with vagus nerve stimulation to induce cortical excitability and seizure activity. And then we did an amygdala kindling model where we also investigated where the relatively acute effect of vagus nerve stimulation was able to affect the kindling process. And basically we were not able to do that and even found again in some rodents pro-convulsive effect when VNS was administered prior to the kindling pulse and an anti-convulsive effect when VNS was applied immediately after the kindling stimulus. So it's not a straightforward question where you can just deliver VNS in an acute situation and hope that you will be able to stop a seizure. We also performed VNS in a pilocarpine model when we nicely demonstrated a decrease in total seizure severity. And we also investigated the effect of stimulating the vagus nerve in the cervical region on potential intracranial networks like the hippocampal network. This was work done by Lars Larsen in our laboratory, investigating both EEG and evoked potentials, and just to demonstrate you that he found significant effects in the hippocampal network, but highly dependent on the type of VNS paradigm that we used. So depending on the type of stimulation parameters that you use, you have a different effect intracranially. This brings me to patients. What do we know? Where there's very little information in the literature or only from anecdotal information, demonstrating that truly while, for instance, a patient is receiving EEG and having a seizure, and you acutely administer VNS, for instance, by using the magnet that patients can use, that you are able to acutely desynchronize the EEG. There were a couple of case reports on that, and more recently, due to the fact that we performed a study with a closed loop approach, indeed, there were some cases of patients demonstrating when you acutely are able to deliver VNS that you are able to shorten seizure activity. I briefly want to share with you one of our cases that, of course, triggered our interest in vagus nerve stimulation and status epilepticus. This is Sarah. She is part of a twins and basically had in her medical history a serious pneumonia with pulmonal hypertension and a thrombosis of the right vena cerebri interna and a thalamic bleeding shortly after she was born. And since the age of about 1 year, she was repeatedly admitted to the hospital with non-convulsive status epilepticus. And again, in 2006, a similar thing happened. And here you see her EEG, which is quite clear. And basically, this is a patient that was treated in the pediatric intensive care unit with all the typical progression of anti-epileptic drugs and eventually also anesthesia, resulting into a EEG like this, burst suppression pattern with bursts that are clearly still quite epileptic. And we are now almost 2 weeks later, any type of anti-epileptic drug has been tried, and eventually the adult department was consulted for a multidisciplinary meeting to investigate whether this patient could be a potential candidate for surgery, despite the fact that she had generalized abnormalities on her EEG. And basically here what you see is indeed the sequelae of her postnatal right thalamic bleeding. So it was decided that the only option for this patient would be vagus nerve stimulation, and we did perform vagus nerve stimulation in her. She was under continuous EEG monitoring, and we had over a 1 to 2 day period a stepwise increase in vagus nerve stimulation parameters up to 1 milliamp. The thiopental at that time was stopped because she was going into multiple organ failure, and we further increased her output current up to 1.75 milliamps. And this is the EEG that occurred after 6 to 7 days of vagus nerve stimulation. And of course, I'm showing you one of our nice cases. And in the following days, this patient gradually regained consciousness and was extubated. And actually, we have been following her up now for 15 years, and this patient is still seizure-free on VNS and 3 anti-epileptic drugs. So basically, we regularly get this question in refractory status epilepticus. And a couple of years ago, together with Maxine Gibuet and Professor Trinka, who is here in the audience, we performed a review on all the cases that were published in the literature. And we came to 28 patients and found a success rate in generalized epilepsy in up to 76 of the reported cases and for focal epilepsy or partial epilepsy in about 30% of the cases. So we did an extensive literature research. Studies were included reporting the use of vagus nerve stimulation for both refractory and super-refractory status epilepticus, and the primary endpoint was the cessation or not of the status epilepticus episode. We also had a positive outcome definition that you can see here. And we did a lot of, or tried to do a lot of data extraction, and most importantly, of course, on, for instance, time, duration of the status epilepticus prior to VNS, and then time to cessation, which is, of course, quite important. We eventually got 25 manuscripts, clearly all class 4 evidence, 44 patients. We excluded these patients who had epilepsia partialis continua, ASs, or repetitive seizures following acute encephalitis. And that gives us the result in 37 patients where indeed cessation of status epilepticus was reported in the magic 73%. In 20% of patients there was no cessation. There were 3 fatalities due to the underlying condition. And then also very nicely, for most of the patients we had information on duration of a status epilepticus, and if you compare that pre and post VNS implantation, it was decreased from 21 days to 8.5 days. So if we consider the positive outcome that we defined, these numbers were even higher, and the VNS parameters were reported in these publications in 20 patients, and they were typically what we see in regular treatment of patients with epilepsy and vagus nerve stimulation. So in conclusion, due to the high case fatality in refractory status epilepticus, off-label treatments are typically, that are approved in drug-resistant epilepsy patients are tried in patients, even if there is no proven efficacy for refractory status epilepticus. VNS seems to have the potential to interrupt these episodes in a high number of patients, but we have to realize that this is data, of course, from class 4 studies, and our major issue probably lies here. There is a high risk of reporting bias in the sense that certainly VNS has been tried in refractory status epilepticus unsuccessfully, but these cases are most likely not reported. There were certainly also missing data in our analysis, and primarily, for instance, with regards to EEG outcome. There is limited knowledge for other neurostimulation modalities. There are a couple of cases with responsive neurostimulation, with deep brain stimulation, and also the non-invasive approaches like high-definition transcranial direct current stimulation is being tried, but really it is too early to see whether this can help these patients. So it's clear that there is an urgent need for prospective studies to investigate the role of acutely delivering VNS in status epilepticus, to identify optimal stimulation paradigms for this acute effect on the brain, also to identify the timing of the implantation. Should we wait until we are speaking about refractory status epilepticus? Should we first try the ketogenic diet? So should we do it together? There were initially some publications that they have a synergistic effect. Can we identify potential synergies with pharmacological agents or non-pharmacological treatments? And very important also, we are speaking here about an expensive therapy. We need to think about cost-benefit. Of course, if you realize that a patient in intensive care unit per day in Belgium, and most likely in most countries, is extremely expensive, and we once calculated that in 3 days of the intensive care unit pays back 1 device for treatment. So I'm not advocating that we have to do it in all the patients, but this, with regards to cost-benefit, these are expensive patients already. Of course, sufficiently powered randomized controlled trials are difficult in status epilepticus and maybe even extremely challenging when we want to try implantation with devices and therapies with devices. The impact on clinical care and practice, currently I can only say that there is no true evidence for the use of neurostimulation to treat refractory status epilepticus. We have positive reports of many cases for vagus nerve stimulation, but these are class 4 studies, just demonstrating that there is a potential. Thank you very much for your attention.
Thank you so much, Dr. Wong, for a wonderful talk. Usually, when I think of refractory status epilepticus, I'm not feeling very hopeful, but today, with all of these presentations of other alternatives for management, I am feeling very hopeful, so thank you very much. Our last speaker today is a very dear friend and fierce advocate for his patients, particularly in the topic that he will be discussing today. It is my distinct pleasure to introduce Dr. Steven Van Herens, who's an associate professor of neurology and medical education at Northwestern University at Feinberg School of Medicine. His clinical research interest includes neurostimulation, identification, and treatment of autoimmune-associated epilepsies and new-onset refractory status epilepticus, or NORS. He is very invested in medical education to the benefit of his many students, residents, and fellows, and he currently serves as the director of the medical student education in neurology, and he's the chair-elect of the Consortium of Neurology Clerkship Directors of the American Academy of Neurology. Steve, it's a pleasure to have you. Thank you very much.
One second while I pull up my talk. Okay. All right. I'm Steven Van Herens, as Adriana. And thank you for having me. And thank you all for staying here on a Friday night. Still a pretty full room here. So we're going to be talking about the use of immunotherapy in the management of refractory status epilepticus. I do have some disclosures. Only really the extinguished trial is of any relevance. But I think the biggest kind of disclosure is that there actually is no FDA-approved treatments for autoimmune encephalitis or autoimmune-associated epilepsy. So we're going through it. So we might as well just get into it because we're running low on time. But as we've been alluding to with all the speakers today, status epilepticus is often, though, etiologically usually fairly easier to figure out, like either the patient stopped taking their meds or they have a large subdural. But in 20% of cases, this initial workup, might be unrevealing, and then you're left with difficulty in pinpointing one of the many uncommon causes of status epilepticus. So we're going to focus on autoimmune etiologies. And so despite the proposed treatment algorithms, as our prior speakers have brought up to 40% of status epilepticus remain refractory. And so finding an etiology of status epilepticus can have therapeutic and prognostic implications. And then delayed recognition may contribute to a poor outcome. So an immune etiology to epilepsy, acute seizures, or status is also becoming increasingly recognized. And a Mayo study found that 20% of adult patients with epilepsy or status epilepticus of unknown etiology were seropositive for a neuronal antibody associated with autoimmune epilepsy or encephalopathy. And so recognition of the possibility that seizures can be the result of autoimmunity or inflammation can have profound effects on treatment or outcome. But like everything in neurology, there's always a lot of caveats. So patients with longstanding epilepsy can have these kind of low, especially serum titers of, undifferentiated voltage-gated potassium or GAD65. And then you have these non-specific serum antibodies too, like ANA, TPO antibodies, with the former, Hashimoto's encephalopathy. And so at our study, in a little study, we did look and found that these actually are more prevalent in autoimmune encephalitis and autoimmune epilepsy, but definitely not specific. And so I'm a clinician and not a basic scientist, but we have to kind of go through a broad overview of the immune system, really, especially for those who haven't thought about this in a while, because when we really talk about immunotherapy, we're thinking really kind of broadly of two arms of the immune system, which interact in a very complex way. So I'm going to try to make this as simple as possible. But when you think of why would someone even develop autoimmune epilepsy or autoimmune encephalitis, you know, there's really kind of, I like to put them into three broad categories. You have your paraneoplastic, which have an underlying tumor, maybe with molecular mimicry, with then autoreactivity, or you might have a virus, like like herpes simplex virus, which has a known association with NMDA receptor encephalitis, or it might just be idiopathic, and we have no idea. And so then we'll divide the immune system into two broad categories. You have the B-cell mediated autoimmunity, which are, you know, our good friends B cells going to plasma cells, which then make antibodies that are presumed to be autoreactive for the case of this talk. And these are going to be antibodies that are directly pathogenic. And just for some name recognition, these are like your voltage-gated potassium, subtypes NMDA, GABA, AMPA, and they're directly pathogenic. And that makes sense that these types of conditions would then respond better to like plasmapheresis, where you're removing that pathogenic antibody. And then you have your T cell line, which are much harder to treat, which we'll get to, where you have where the antibody is actually directed to an intracellular target. So therefore, it shouldn't really reach that target. And so these are more biomarkers of injury rather than directly toxic antibodies. And so just kind of, I won't go through these long lists because we're going to be clumpers higher yield today in 20 minutes instead of splitters. But there's multiple different cell surface antibodies like NMDA, voltage-gated potassium, AMPA. And then you have your intracellular, like anti-Hu, which these are almost always associated with cancer. And so you should really be doing a very thorough paraneoplastic oncology screen, except for GAD65, which is has its own difficulties in treatment for any of you with those patients. So now let's also take the caveat before we start taking a deeper dive into actual treatments in that what is autoimmune epilepsy? Because we all know like epilepsy is an enduring kind of predisposition to have seizures. So while some of these patients, if you treat them and you get to hold of these seizures with immunotherapy early, they might not even have long-term epilepsy. So seizures, like we had talked about, have been well recognized in a prominent manifestation of autoimmune encephalitic syndromes. And so when we refer to kind of to autoimmune epilepsy, or like when you say autoimmune dementia, you know, it's really, you're kind of referring to the most prominent symptom. For the sake of this talk, it will be epilepsy and seizures. And so the ILAE then, you know, has this immune category. However, like we were just saying, that, you know, many patients with cell surface antibodies especially can achieve complete seizure freedom after treatment. So now we've kind of subdivided these into acute symptomatic seizures secondary to autoimmune encephalitis and autoimmune associated epilepsy. So the symptomatic seizures are going to be more of that you know, antibody-mediated cell surface where you're actually having antibody-mediated ictogenesis. And these are going to be usually more responsive to immunotherapy, more so than anti-seizure medications alone. And the outcome, especially if you get them early enough, they might not have long-term epilepsy. Autoimmune-associated epilepsy, on the other hand, these are like your GAD65 or, you know, anti-Hu, and these are going to be a combination of epileptogenesis due to structural, like post, you know, encephalitic pathology, so you have that structural piece, and then you have your ongoing T-cell mediated brain inflammation piece. And so when you're treating these types of patients, you know, it's very challenging of the balance of immunotherapy and anti-seizure medications to really get control of their seizures. And the unfortunate reality is in this group is that they are very refractory. And so anti-seizure medications are often ineffective. Epilepsy surgery usually has an incomplete response, and immunotherapy is also usually with a poor response. They're just very pharmacoresistant focal epilepsies. And so this kind of just further is a pictorial study of what I just kind of went through, in that here when you look at the cell surface antibodies, that, you know, all of these, each notch here is a year. These actually stop seizing, while the intracellular ones looks pretty flat because they kind of continue seizing. So how do I approach treatment before we get into specific kind of treatment paradigms? So I do use the kind of Mayo Clinic 3Ms that they have that nice branding on, but it's really true that when you're dealing with a patient in status epilepticus, my first goal is really to get, at least 50% seizure reduction. And keeping in mind that you may not be able to reverse, but only stop any progression. And then you want to maintain that reversibility with the minimal therapeutic dose of an immune suppressant. So, and before you really get started, especially if you're unsure of the diagnosis, you really want to have, and I can't stress this enough, objective markers for what you're treating. The worst thing you want to get into is blasting someone with immunotherapy and being like, I think they're a little better. You really want like very specific, either seizure frequency with their cognition, and not just cognition like, oh, they were kind of off before, but like a MoCA or some sort of objective sign to follow. Or you're following like MRIs, PETs, something objective. And so this is kind of the algorithm that we published 2 years ago now, which is based off of Jenny Lenoila's paper from 2016, just updated a little. And so we'll go through this kind of piece by piece. And so if you don't have an antibody identified or you're still waiting for it, as soon as I have essentially like your herpes virus is ruled out, like you get started with some steroids, IVIG, maybe you even plex them. And if you don't have improvement, especially in an unstable patient who might be in status, that's usually when you start increasing the therapy with rituximab, especially if you end up getting a cell surface antibody coming back versus like cyclophosphamide. And if you do get improvement, this is when we go to that kind of acute symptomatic seizures versus an enduring autoimmune-associated epilepsy, in that like LGI1 or some of the cell surface are monophasic diseases at times. So once you get control, you don't just stop the immunotherapy, but then you start slowly tapering it over months because you don't want an immediate relapse. And then you if they relapse further out, then you kind of know that they need that enduring continued immunotherapy. And then you have to bridge that therapy, knowing that a lot of these immunotherapies like azathioprine and things might take like 12 weeks to really kick in. So then you have to redo the steroids and get them bridged back onto immunotherapy. Now, if it's intracellular, then I don't really waste any time. I usually just start cyclophosphamide, monthly pulses. I mean, you really, as we've said many times today, time is brain, and their brains literally start to melt away if you don't get control of this very fast. So, and then with all of these, you definitely want to do your tumor screen too and treat if there is an underlying tumor, you don't just punt it to oncology, but recognizing that you can't just remove the tumor, these antibodies are already made and they still need immunotherapy. Okay. So, like I said, once you get the steroids or IVIG, you start gradually extending it. If you're using oral prednisone, which I don't recommend because a lot of these patients have a lot of psychiatric comorbidity and that can really agitate them, so I do prefer IV pulses if you're able. But I usually start with 60 and then slowly wean, and then remember to overlap. And like I said, there's always caveats to all these types of treatments, and it's important to note that, like I said, just because you have a neuronal antibody does not guarantee a good response. And like I said, successful immune treatment may be marked by just stopping clinical progression. And it's also important to recognize that a full recovery may take months. And seizures may show early improvement, but cognitive improvements can take years at times. So really keep that in mind. Don't just say that they failed. And so approximately 20 to 50% of patients with the autoimmune encephalitis may show inadequate response to second-line therapies. And so, for instance, bortezomib I've now used in very refractory NMDA patients now with positive success too. So there are other kind of new novel, tocilizumab with IL-6 have emerged as novel second-line immunotherapies for management of refractory cases. So anti-seizure drugs, we'll stick to immune therapy, but I do want to just kind of briefly state, this one paper which did show that carbamazepine was more effective than levetiracetam in reducing seizures in anti-LGI1 encephalitis. So in these patients, seizure med-wise, I do try to stick with sodium channel blockers in general. So let's kind of switch gears from autoimmune encephalitis to more what is thought to be more of an autoinflammatory kind of disorder with NORS. So NORS, being new onset refractory status epilepticus, rare devastating condition, characterized by de novo onset of refractory status epilepticus without an identifiable active, structural, toxic, or metabolic cause. And it is a clinical presentation rather than a specific diagnosis. That's all this definition is written by people in this room, actually. So FIRES, a subcategory of NORS, requires a prior febrile illness starting between 2 weeks and 24 hours before the onset of refractory status epilepticus, with or without the fever at onset. And it does apply to all age group. That's not just pediatrics. Just keep that in mind. And cryptogenic, if it's cryptogenic, meaning it's unknown etiology with no explanation. And about half of them will have that kind of unknown cryptogenic presentation. And interestingly, these cases do not differ much from autoimmune cases, suggesting this kind of similar etiology and questioning if there is unidentified antibodies. And the CSF abnormalities are similar in both the cryptogenic cases and autoimmune infectious cases too. And there has been shown now evidence of these proconvulsive cytokines have been documented in the CSF. So Ronnie Wigstrom, who's in the audience, as well as 48 experts, at least 7, I think, are in this room, created a total of 85 recommendations concerning diagnoses, treatment, and follow-up. Were developed to aid clinicians and present this care. So Dr. Wigstrom presented this last year, so I won't go into full detail, but just we'll go kind of use an illustrative case and then come back to this algorithm of how I use it. So this is a patient I had this summer. She's 20 years old. She was a college student, collegiate athlete at a university in Chicago, and essentially had presented with what was thought just to be a regular virus. She got a fever to 101.8, headache. She had lymphadenopathy. She had a negative respiratory panel. They checked like COVID, of course. She did have kind of a low white count, but not like dangerously low, but a little leukopenia. And she continued to have malaise, headache, but no neck stiffness like meningeal signs. She had poor oral intake, and she was started on meropenem and encyclovir empirically as she started actually having generalized tonic-clonic seizures. However, not just one. She had one after another, and then followed by multiple with focal onset. She could have left head version, right head version, and when she was placed on EEG, she just seized and seized. They were coming from both sides. And so her initial CSF was actually fairly bland, except for some elevated protein. And I'll pretend that we got all these antibodies back immediately, even though we know it takes weeks, but they were negative. So she also had a negative MRI initially and a negative cancer screen. And her follow-up lumbar puncture had like a low kind of white blood cell lymphocytic predominant. And then she started, as we were talking about MRI changes with status, she started developing some nice T2 changes in her mesial temporal lobes. So seizures continued despite now 5 seizure meds. She was placed in burst suppression. I should also say, too, she had next-gen sequencing for any viral, which were all negative. And we did actually order initially a cytokine panel, which, as you know, didn't come back immediately either. We'd already started treatment at that point, but it did come back elevated with IL-6. So in this patient, she had what I would classify as FIRES. And so, the initial treatment is really stabilization, which we didn't really talk about in this group, but, with anti-seizure medications, she was given anesthetics, and essentially that is when we started with the concern that this was FIRES, is when we started immunotherapy. So she got steroids and IVIG, and we did initiate in the ICU ketogenic diet and got her into ketosis as well. And we then also elected to use an IL-1 receptor blocker, or antagonist, I should say, anakinra. And so she was started on that as well. And I was like a positive story. And so now made these slides a month ago. So now we're 4 months out, and she is back in college, and she's playing Division I volleyball. And so she's doing amazingly well. On her ambulatory EEG, she still has bitemporal sharp waves, but hasn't had any subsequent seizures. I have now weaned her off steroids, and she's on a lower dose of anakinra, but now we're working on kind of lowering seizure meds. I never like to lower immunotherapy and seizure meds at the same time, because then if they have a breakthrough seizure, you don't know what to do. So one at a time, if I can give anyone any advice. So take-home points, despite proposed treatment algorithms, up to 40% of status remain refractory. So don't forget about immunotherapies and immunoetiologies. Delayed etiology recognition can contribute to poor outcome. And, I didn't show these slides, but delay in outcome is associated with continued long-term seizures. So time is brain. I don't know how many times we say that today, but it is important to note that the presence of neural antibody does not guarantee a good response to treatment, and a successful immune treatment may be marked by just stopping clinical progression and not necessarily reversal, and that it can take months to fully recover. And these are my references, and thank you.
Thank you to so many of you for being here and sticking it out into the evening. I know we're a little bit behind time, but we're still going to try to have some time for discussion and questions for anyone who is able to stay here longer. So we'll invite all of our experts up and open the floor to any questions or comments.
Thank you very much. This was an excellent overview about the whole story. Can I ask you about the immune treatment? So one question related to the case and one related to your view. So you mentioned when you don't find any antibodies, you don't have any clue of immune treatment, or maybe to clarify that, do you then start immune treatment even without any antibody? That's number one.
Well,
and based on what?
So that is a very loaded question. So I didn't go through the whole diagnostic. That would be a whole separate lecture. But if you have, if you have a degree of suspicion, right? So I do for instance, if you don't treat these patients a lot, there's the APE score, if for any of you familiar with that, the antibody prevalence in epilepsy and encephalopathy, which is a nice kind of framework to think about. And, when you kind of go through possible, probable. I mean, so there is some evidence, though, that, for instance, you have, it's a subdural or something, that, there is, with these refractory cases, some degree of inflammatory component. And so, but to answer your question short, no, I don't just immediately immunosuppress everyone.
Okay. I'm glad to hear that. And
many of our colleagues do in the intensive care unit. They sometimes do it before we arrive.
Exactly, yeah.
So
and I think it can be problematic because these are weapons and...
well, especially in someone laying there not conscious, yes.
So the second question is your lady, the volleyball...
Yes.
A very impressive result, but she had bilateral hippocampal abnormalities, which you said. So what was the outcome? Usually they have an atrophy and cognitive decline.
So she didn't have, so I should preface that. So she had more diffusion restriction, but she didn't lose a lot of volume in her hippocampi. They were bright, but we basically acted very quickly. And so hopefully that spared her. I mean, cognitively, she's still on 4 seizure meds, and she's taking a full load of classes. So I think it's kind of impressive. She probably had a good cognitive reserve, too.
Hi, I have a question for Dr. Sarenka about the ketogenic diet therapy. How many of the patients in those cases where the status epilepticus resolves, how many of them end up staying on ketogenic diet therapy? And if they don't, what's like a good exit strategy for it?
Sure. So I'm an adult epileptologist, and with our adult patients, what we tend to do is that as soon as they're able to eat by mouth, we put them on a modified Atkins diet instead. We have had patients, I mean, it's a wonderful situation where you put a patient on keto when they're intubated and sedated, and then they wake up and they're like, we're doing what exactly is happening right now? And I have had that situation where a patient will just be like, nope, no thank you. And so we try to incorporate a kind of a more liberal diet in that case. In general, for pediatrics, the patients won't stay on the diet long term. In this case, we often will offer after like 6 months for a patient to come off the diet. I was hearing your story about that one patient. I mean, I have a gentleman who we treated for SRSE in 2014, and he's a lawyer, and he's doing very well, and he's still on the diet now and has decided he doesn't want to stop. So, there's lots of different variations on the theme, but if you want to, usually we'll try a more liberal diet for about 6 months, try to taper off medication. I agree with you, don't do too many things at once, and then see if you can get rid of the diet at that point. We have had patients, and there are patients in the literature as well, where the status epilepticus stopped, and then they went to a rehab center or somewhere else, and the diet was accidentally stopped and actually went back into super refractory status, and in one case the patient actually passed away because they couldn't control it once it happened again.
Thanks for the great talks. Thanks. I have one comment and I'll ask a question. One comment is sometimes when we encounter even resistance to rituximab, we have tried intrathecal rituximab, and it appears to be pretty well, at least in some patients, it works out pretty well.
Did you say tacrolimus or what?
Rituximab.
Oh. Yeah.
Intrathecally, yeah.
Yeah. So intrathecally, is that what you said? Yeah, so rituximab doesn't really cross the blood-brain barrier well. So if you have intrathecal synthesis of NMDA, I've seen people do that. They've done it at Mayo. In those cases, I usually go with bortezomib, actually, which is keep in mind, this is like what you're talking about, the consequence of, so I had a patient with NMDA receptor encephalitis that was in a coma for about 6 months, used bortezomib, and now she's actually back to work and doing really great, but her immune system is gone now. We have to give her IVIG because it never really came back. So you are playing with, these are big guns at that point, but it was worth it because she was in a coma, but.
Yeah, this patient is actually a doctor now. So.
Yeah, she's actually also an advanced practice provider.
Another question is about we know about the steroid responsive encephalopathy, the TPO Hashimoto. What is the usual approach that you take?
So I like to use TPO and ANA as a marker of autoimmunity. I don't think that they're causative antibodies. A lot of them, at least in my experience, end up having LGI1 or another more specific antibody come back when the panel. So I kind of just use it. We did that analysis. It was in our database, just looking at the positivity, and the positivity is higher in autoimmune encephalitis, but it's not specific. And so I just kind of use it as another data point rather than a definite, if that makes sense. Yeah.
Thank you for the talks again. I actually have a short question for each one. For the VNS, what was the youngest patient that was implanted in super refractory status? Do you know?
No, it's a good question. I would have to go back. Eugene, do you remember? In general, in VNS, it's less than it's even a couple of weeks. But in our review, I would have to recheck it. Don't know by heart.
I'm asking from a personal experience. We currently have a 6-month-old who's in
Oh, yeah, but
super-refractory
it's-
status on the ketogenic diet too. So my second question was, if you don't notice improvement, do you like
Yeah.
taper it, wean it off, especially that it's been like a week or longer?
Yeah, so if you have successfully gotten into ketosis, again, with air quotes, because we don't know exactly what that should be, but I would say if you're at 2 or 3 millimoles per liter of beta-hydroxybutyrate consistently, and it's been a week and the diet hasn't done anything, typically we don't even taper it, we just stop it. Yeah, we give it a week where we are confident that we've done the diet right and it just didn't work, and then we say, okay, we can stop it now. That's typically what we do.
My last question was about your case,
Okay.
athlete. What made you want to get a repeat lumbar puncture if the first one was bland?
Oh, so the first one wasn't at our hospital. So it was a transfer, and I wanted to send the antibodies and things, so that's why. Yeah.
Thank you for wonderful talk. I have a just quick question, very specific question about choice of anti-immune therapy. So I just wonder how you differentiate or differently between anakinra and rituximab for autoimmune encephalitis and status epilepticus. We recently have a patient, younger kiddo, maybe infant, who had an abrupt onset of status epilepticus, every workup negative. Some doctor or some specialist raised the concern it could be an autoimmune encephalitis, maybe a nose. And then we decided to use the autoimmune therapy. And the steroid, IVIG, everything done, but nothing helped. And then question is now, somebody said, oh, let's go to the rituximab. Somebody said, based on some Q case report, let's go to anakinra. My understanding is anakinra is made for interleukin-1. And then rituximab is for B-cell. How do you use them different?
So that is a great question, and if you notice that rituximab is on both algorithms, so there isn't necessarily a right answer, it's what actually works, but I mean, rituximab in my mind is very clear if you have a cell surface antibody. Or like you can also think of it as like if you did plasmapheresis first and they responded well to plasmapheresis, then you have every reason to believe they will probably respond well to rituximab. You can use that as like a surrogate kind of marker for rituximab. No, if you already pheresed them and you really had no response, then, and that's the thing when you're thinking, and we don't really know, this isn't actually studied, so, but it makes sense that there probably is, or could be some, I'll just say could, have some efficacious in autoimmune encephalitis too, even if there was an antibody of using and disrupting an inflammatory cascade with an IL-1. The nice thing with anakinra is that it actually has a short half-life too, so if you stop it, you can reverse as opposed to like tocilizumab or some of the others, if they start getting like infections and things. So, so there is less risk in some regard. But you can always supplement with IVIG for rituximab too. So just some caveats there. Yeah.
Thanks again for wonderful talks. I have a question regarding ketogenic diet and VNS, and the question is quite similar for both therapies. And I was wondering, is there any guidance on how soon these therapies should be considered in refractory status epilepticus or super-refractory status epilepticus? And the second question is, do we have any data looking at the time of initiation of the therapy and its effectiveness?
So with regards to the diet, I would propose that once the patient has a feeding tube, they could have the ketogenic diet in the setting of refractory status epilepticus. I mean, I really don't see, except with the exception of the very young children, because some of those labs that you have to send don't come back in that time frame. But if you have, for instance, an adult, likely those things would have declared themselves before the person is 18. So we typically won't send those labs and wait for those labs to be able to start the diet. So that's the answer to the first question. And there really has not been enough data collected to see about the how quickly you respond. I mean, there are things like that for like ketamine, for instance. You know that if you give it within the first week, it works much better than afterwards. But there just hasn't been as much data for diet. But certainly, it's something to look into.
Yeah, I think for vagus nerve stimulation, certainly something like ketogenic diet, if I hear it now, is less invasive, is easier in a setting of the intensive care unit if you have the guidelines available or a dietitian to do that. For vagus nerve stimulation, at least I would now, with the data that we have, wait until you have tried some anesthetics for 24, 48 hours to see whether you can get them into this burst depression and then release it again, maybe even do that 2 or 3 times before you would go for an implant. And of course, the question is then, I showed you a case where it worked. When do you decide that it doesn't work? Some of the patients die indeed due to the fact that they go into multiple organ failure. How fast can you titrate the therapy? Relatively fast. There's little to lose in these patients. But indeed, you can ask yourself, how far do you take it with vagus nerve stimulation? You can keep increasing the output current. It's also very difficult to say if it doesn't work after a week, it's never going to work. I'm not sure. You just keep going, I guess, until or the patient dies or you have some efficacy. And certainly there will be non-responders. But for now, I think at least you should try an anesthetic first. And when I hear today, and most likely you are somewhere in the middle, in between, depending on what your diagnostic procedures are, but ketogenic diet should be early on in the trajectory.
Thank you.
Nick and Adriana, Toby Lodenkemper, Boston Children's. Great presentations, really awesome selection of 3 exciting topics. I think what becomes more clear to me after this workshop and also after Eugen's meeting in Salzburg is that the sooner we get patients off continuous infusions, the better the prognosis. And I don't know if it's just the continuous infusions or the patients are doing overall better, but the 3 therapies that you presented and the 3 approaches are really 3 alternative approaches to get patients off. Now, looking back, we've been talking about this for the last 10, 20 years. I know that at the NORS meeting, and Ronnie might present an approach how to treat autoimmune and NORS and fires. So Dr. Van Herens, you're off the hook, but I still want to target a question to Mackenzie and to Crystal. I mean, both of these therapies could be really implemented in a trial relatively quickly, and I don't know, I think most people have seen the ketosis protocol. Let me just, put my finger on the wound. Where does it stand? When are we doing the next trial? Because the patients are already off food for 24 hours, so you could implement the ketogenic diet really in most patients relatively soon. And then, Dr. Vonk, when is a trial coming?
For any trial on status epilepticus, I look at Eugene.
So sadly, apparently we are meant to get more preliminary data before we can move forward with ketosis. So that is the stage we're at, where the evidence that I presented today wasn't sufficient to support the proposed trial. So there will be more evidence needed, but we'll hear more about it in the future, I hope.
Let's hope so.
Thank you again. Thank you for being here. I hope you all have a good night.